Everyone, it's Jake here from IBPF. Thank you for joining today's webinar, Understanding Bipolar Disorder and Co-occurring Borderline Personality Disorder, Identifying Symptoms and Potential Treatment Approaches. We are honored to be joined by Dr. Christina Temes. And Christina Temes, PhD, is the Director of Psychology at the Dodden Family Center for Bipolar Treatment Innovation at Massachusetts General Hospital and an instructor at Harvard Medical School. Dr. Temes's research and clinical interests focus on the phenomenology and treatment of mood disorders, personality disorders, and their comorbidity. At MGH, she is involved in multiple projects using learning health systems and collaborative care frameworks to improve care and treatment delivery for patients with bipolar disorder. I want to let everyone know that there will be a question and answer session at the end of today's talk. You may type in your questions through the Q&A section on your display at the bottom of the screen at any time throughout the presentation. So Dr. Temes, I want to thank you so much for joining us today.
Great. Thank you, Jake, and thank you to everyone who's joined the webinar. I can't see you, but I know you're out there. So this is really an exciting opportunity. I will be sharing some slides, but hopefully, we can keep this light and fun, and I'll be interested to answer questions after the talk. Let me just get my slides up here. Okay, I think we're good to go. All right,
perfect.
Great. So like Jake said, I'll be talking a bit about the co-occurrence of bipolar disorder and borderline personality disorder. And specifically, I'll be talking about some of the research that's been done in terms of, characterizing symptoms that are typical of this group of individuals, and also get into talking a bit about treatment approaches that might be promising for people. First off, I just want to give a shout out to World Mental Health Day. Very cool that I get to give this talk today. And there are lots of great resources this month and today on the web. So I'm glad our talk got to coincide with this important day for all of us. So just to give a little bit of an overview of what I'll be talking about, as I said, I'll be reviewing some of the research that's out there about bipolar disorder and borderline personality disorder. I'll begin by talking about some areas of overlap, and I think sometimes a little bit of diagnostic confusion between the two disorders, as well as how they're differentiated and why that's important. I'll also be talking a little bit about, what we know about sort of on average, what the characteristic features and course are for people who have both conditions. And then I'll also be talking a bit about some of the existing treatment research, like what we know so far, and maybe what we can consider when we know these two conditions are co-occurring. And I'll be wrapping up by talking about some recommendations about, what we can do right now. I'm sitting in a clinician researcher seat, but I think, I know there are also people with lived experience in the audience. So kind of thinking about ways that we can use this existing information that I'm going to review to better understand folks' experiences and ultimately help people. And, if you're kind of coming from a lived experience perspective, hopefully this information might also help you, talk with clinicians or maybe connect with services that could be useful. Also, a bit of a shameless plug, myself and some colleagues recently published a review of a lot of this information in the Bipolar Disorders Journal, which was a really rewarding article to write. So this is out there if you have access to articles. If not, feel free to reach out to me. I'm happy to kind of point you in the direction of getting a copy. So like I said, I'm going to start by talking a little bit about some similarities between bipolar conditions as well as borderline personality disorder. So kind of what does the space in the middle look like in terms of features that might, at least at face value, seem similar when we're talking about these two conditions. Because I think sometimes people, clinicians, others, when we're reading kind of lay media, can get, there can be some confusion between which condition is which. because there are some kind of features that do overlap or, can kind of be similar types of experiences. So I'll first highlight sort of this area of overlap in terms of features that are shared by people who have lived experience of bipolar as well as borderline personality disorder. And these might be even reasons where people are presenting to treatment or describing to their clinicians that they've been experiencing. So these include, some challenges with mood, certainly, and affect instability, which is, just kind of experiencing a lot of ups and downs in one's mood and experience and emotional experience. Um, Experiences with anger, frustration, agitation, certainly, sort of risk for suicidal thoughts and behaviors or self-harm thoughts and behaviors, as well as, urges or actually engaging in behaviors that are maybe more impulsive or riskier um, for one's, well-being. And so these are often, symptoms that people both with bipolar conditions as well as borderline personality disorder report experiencing. I think there are some, areas of overlap, but there are also some key differences in terms of, how these symptoms are on average experienced by people who have a borderline personality versus bipolar condition. So I'll talk a little bit about those and some areas of kind of distinction that are maybe unique to each condition. So some things to think about is even if people are kind of reporting these kind of key areas of difficulty, is sort of the course of those areas of difficulty might look different between the two conditions. The time course, sort of how these things kind of play out over the course of one's life, both in the short and long term. In addition to the kinds of situations in which these things are likely to develop. So, I'm preaching to the choir here at the International Bipolar Foundation, but we know from, bipolar conditions tend to, when we're kind of reducing them down to their parts, have distinct episodes. There's depression, mania and hypomania, as well as mixed episodes. And when we're talking about bipolar conditions, we're typically talking about mood shifts that are lasting days to weeks at a time. Although certainly, there can be some subsyndromal symptoms in there as well. In terms of time course, we also realize that mood can be stable between episodes. So people can experience periods of time when there's maybe more mood instability or an episode that's, characterized by a particular type of mood, and then periods of time when maybe their mood is more neutral or positive. We also see insomnia and other sleep and circadian rhythm problems in bipolar conditions, which is a bit unique to them. And one thing I realized I didn't put in the circle here, but I think is relevant is that, although there can be sort of stressful experiences that precipitate some of these mood shifts, that is not always the case in bipolar disorder. There's not always sort of a clear trigger or precipitant to the beginning stages of some of these mood episode shifts that we see. In borderline, sort of again, talking kind of more generally speaking across individuals, typically people report kind of more chronic affect dysregulation. So this might be something that they, struggle with, not necessarily on an episodic basis, but that is something that they're feeling kind of more reactive day to day. It's more typical of them throughout their life. And sort of the more distressing shifts in mood and affect can be quite sudden. So sometimes people report this happening on the scale of minutes to hours, as opposed to lasting for days or weeks, for instance. And often, sometimes these shifts in mood and affect can be linked to particular types of stressors that, are generally seen to be particularly distressing for these individuals, which maybe sort of stressors in the interpersonal domain. So kind of in relationships, situations that might bring up concerns about abandonment, other types of situations that are stressful and then can produce a really strong reaction in mood or affect. Often folks with borderline personality also report experiences of emptiness, which can feel, I think it's described differently by different people, but can sort of feel like having no feelings, feeling empty. like kind of nothing is inside. And that's often also an experience that, can be more characteristic of borderline personality and is a bit unique. This is definitely a non-exhaustive list, but I think gets at, although people kind of could use similar language to describe what's going on with themselves, there's some important questions to ask around, um, sort of the time course of these changes, what seems to maybe trigger some of these changes, et cetera. Other areas of overlap that I think are important to identify in terms of folks' experiences are the experience of underdiagnosis and delayed diagnosis. So again, I know I'm preaching to the choir, but we know that, a lot of individuals with bipolar conditions, are in mental health treatment for many years before getting an accurate diagnosis and getting a treatment that's centered on their bipolar illness. We also see that on the borderline personality side. I think anecdotally, I worked in the personality disorder world for quite a few years, and now I've been more in the mood disorder world. And I'm seeing like similar struggles that people are reporting of it taking a very long time to find out really, how to best characterize what's going on for them and how to best find treatments that actually work for them. Um, and one reason for this is we, for both conditions, I think see generally kind of lower rates of screening in general practice than for some other conditions. And, often it's not necessarily common to screen for personality disorders in general practice. On the bipolar side, often we screen for depression, but we don't necessarily screen for mania or hypomania. So that information is lost and is, of course, incredibly relevant to figuring out kind of what's going on for, you and your health. Um, Other, kind of experience similarities is that often people with both conditions come to treatment kind of reporting similar types of complaints. So they might be reporting depressed mood or difficulty kind of regulating emotions, and could, at least based on that initial why are you here, what's going on for you type of question, could seem pretty similar, particularly if we're not doing a lot of assessment after that. And both groups also tend to have pretty high rates of treatment utilization, kind of receiving a lot of different types of mental health treatment, kind of maybe engaging with the emergency department or having inpatient hospital stays. So that could certainly be costly for, in terms of, kind of our public health system, as well as for individuals who are having to utilize, these types of treatments in order to, kind of maintain their stability. And both conditions, we know can, are heterogeneous, so people have different experiences, but can carry a lot of morbidity. And that's, meaning kind of interference with functioning, with doing the things that are meaningful in one's life due to, these types of symptoms that they're experiencing. So we were talking a little bit about the similarities and the overlap and sort of some areas of nuanced distinction. Some other areas of divergence, which I'll get into, are, and I've touched on in the Venn diagram, are the phenomenology and course of both disorders. So phenomenology is a big word, just sort of describing what people's, kind of internal described experience and observations of what it feels like to, kind of have the experience of these conditions is. So what types of symptoms, experiences with the world they're describing, as well as like course being what that looks like over time, how people do over time, how people do in the course of treatments. So there's some differences in those areas that are important to note. There are also some differences in terms of family history. So people that have bipolar conditions, frequently have other family members who also have a bipolar disorder. That's seen less often in families of individuals with BPD. So you're not necessarily seeing people with primary borderline personality disorder reporting a lot of family members having bipolar disorder. There's also some differences in terms of medication response, and we'll touch on this a little bit later. But for instance, we know that lithium, in patients for whom it's effective, promotes mood stability in bipolar disorder, but not necessarily borderline personality disorder. Similarly, we know that certain anticonvulsants are more helpful for mood as a specific symptom area in bipolar disorder, whereas in borderline personality, they're more effective for symptoms such as impulsivity and risk-taking behavior. Also, I apologize in advance about sort of the acronyms that will appear. I realize BD and BPD are very similar, so I will try to speak out the words to not be too confusing. There are also a lot of other studied factors that kind of differentiate between bipolar spectrum illness and borderline personality. So there's sort of a long history that I won't get into in this talk, where there's some theory around that about borderline personality kind of being part of the bipolar spectrum. And there's been a lot of evidence to suggest that they are actually, kind of distinct conditions, with different presentations and different sort of etiological causal factors. And, these studies sort of look at differences, in, kind of genetic pathways in terms of cognition, brain activation, other types of behaviors. So there's a whole host of literature out there that kind of shows some differentiation between the two conditions. So I guess one question before we get into the co-occurrence is, why is it important to sort of acknowledge this difference between bipolar conditions and borderline personality? One is just sort of the state of treatment is that the first line treatments for both conditions are quite different. So we know that for bipolar conditions, although a lot of people are involved in therapy and other types of psychosocial interventions, medication is the first line treatment. With borderline personality, it's sort of the opposite. So we know that psychosocial treatment, therapy, group therapy, those types of interventions are the first line treatment for borderline personality. And people do receive some pharmacotherapy that is much more targeted on specific symptoms that they are having. And then also, of course, we want to make sure that, treaters understand the patients that they're treating, have an accurate formulation so they can make appropriate treatment recommendations. And also that individuals with lived experience sort of have, kind of an organizational concept that makes sense for them and actually accurately describes what's going on for them, so that, they can also, be educated appropriately about their conditions and ensure that they're receiving quality care. So we talked a little bit about the overlap, a lot about how these are two kind of distinct diagnostic conditions. However, they can co-occur. And so that's what the remainder of the webinar will be focused on, is, essentially kind of what does that look like and what does that mean for how we can best help people. So there's been several studies examining kind of the rates of comorbidity between these two conditions. I'll review a few of these without getting too far into the weeds. But essentially all of the studies here are systematic reviews. So they kind of examine groups of studies that are already out there and combine kind of estimates from those studies to determine, what is the rate of co-occurrence between these two conditions. And they look at them using some different samples, which I'll get into. So this first review of 24 studies, all the studies included in this review, research studies that use semi-structured interviews, which are very, are kind of scripted interviews asking about specific questions with specific logic to kind of then yield a diagnosis that's based on kind of this strict DSM criteria. And in this particular review, sort of when they averaged across these studies, they found that the overall rate of borderline personality disorder in patients with bipolar disorder who were receiving treatment was around 16%. The rates were a little higher for bipolar type 2 compared to type 1. And when they conducted the same investigation, or the studies that looked at this within non-clinical samples, so people that were not actively receiving treatment or were not identified through their treatment, found estimates around 15%. Fernaro kind of followed up with another sort of systematic review of some other studies and a meta-analysis, so combining those studies to then look at the data. and found that the overall rate of borderline personality in bipolar individuals was 21.6%. Again, kind of finding that higher rate within bipolar type 2. And this sort of combines some methods. So there were some studies that use those really structured interviews, some studies that use clinical diagnoses. So like if you went to your provider and met with them, they asked a bunch of questions about your experience and figured out a diagnosis at the end. That would be a clinical diagnosis. Um, and they adjusted for this a bit in the analyses, but found that estimate of around 21.6%. And then a final systematic review found an overall rate of around 22%, with some mixed findings for bipolar type 1 and type 2. It kind of depended a little bit on the study type. And pretty much all of these studies also use those structured interviews. So to summarize, like when we average across studies, the rate is about 20% of individuals who meet for both having primary bipolar spectrum illness as well as borderline personality disorder. And like I said, there's some of these mixed findings, which I won't get too far into the weeds about if this is more common for folks with bipolar type 1 versus type 2. There's quite a bit of variation in rates between studies. So it's not like every single study is finding that rate of 20%, but that's kind of the average, across these different studies. And there are some issues regarding that method of diagnosis that we could definitely talk about more. But essentially, sort of I highlighted that sometimes they used a more structured interview. Sometimes it was based on a clinical interview, similar to if you went to your doctor. And although the method was not directly studied, I think we can wonder about, sort of what that means for these rates. If you're using a more structured assessment, you're most certainly probing the criteria of both disorders than maybe some people do in clinical practice. And so, that could potentially identify more cases than if you weren't asking those questions. But regardless of the type of assessment, all of these are mostly like point in time assessments. So you meet with a interviewer or a clinician and talk about kind of what's going on right now, as well as the history. And I think I'll talk a little bit later about how I think for both conditions, given that the course of these symptoms is so important, sometimes when we just have that one assessment, it can miss some information that can be really relevant. Okay, so now we'll talk a little bit about, what these different, basically how does bipolar illness look different for those with co-occurring borderline personality disorder compared to people that do not that have bipolar illness without this co-occurring disorder. So just some features that again have been found across some different studies. So when we compare folks that have bipolar disorder without co-occurring borderline personality to those who have bipolar disorder and borderline personality disorder, we find that those with the co-occurring disorder have a greater number of mood episodes. So if we ask people how many different mood, either depressive or manic or hypomanic episodes they've had, those with the comorbidity tend to have a greater number. They may also have longer mood episodes. So episodes that just have a longer duration. They also, again, on average, have more elevated risks for suicidal thoughts and behaviors, as well as self-harm and some other kind of impulsive and risky behaviors. Again, on average, can have poorer psychosocial outcomes, and this is measured in different ways. But this includes kind of having some higher rates of unemployment, poorer social functioning, so maybe not feeling as satisfied or not feeling like they're functioning as well in their important relationships, a higher likelihood of being on disability, and lower kind of global assessment of functioning scores. And this is just sort of a global assessment of sort of how they're doing across life domains. So relationship, work, school, if that's kind of relevant to their lives, ability to sort of function independently. There's some emerging data about that this group might have some greater cognitive deficits, and this is particularly in domains that are kind of related to executive functioning. So set shifting, so kind of shifting from one task or one sort of set of roles in a task to another, processing speed, and selective attention. So being able to kind of attend to one thing while trying not to attend to something else that might be distracting. So people that have the co-occurrence report kind of more difficulties in these areas, and that is also seen on kind of more structured cognitive tests. We also see that people with the co-occurrence tend to have other psychiatric conditions when assessed, and higher rates of these conditions and these comorbidities, and these include things like substance use disorders, post-traumatic stress disorder, generalized anxiety disorder, eating disorders, other personality disorders. And one study found that, if you looked at sort of this comorbid group, so people that have this co-occurrence compared to a group of individuals bipolar without the co-occurring borderline personality disorder, and looking at sort of how many people in the comorbid group had 3 or more of these non-bipolar diagnoses, it was the rate of about 71.2% versus those with bipolar without BPD, which is 44.5%, which is a pretty big difference in terms of kind of the rates of these co-occurring conditions. So yeah, I think these kind of all sort of suggest that this can be symptomatically a more complicated course for folks that are dealing with this co-occurrence. It doesn't mean that every single person with this co-occurrence is having all of these different things. Again, this is on average across groups of individuals. But it can, there can be more complications in terms of just the symptoms of both of these conditions over time, in addition to there being other conditions on board that can be challenging for folks. Just some other features, and these are kind of more contextual features of folks that have the comorbid presentation versus, just bipolar disorder. We often see in these folks an earlier age of their onset of bipolar disorder. So, they have their first mood episode earlier in life than folks that have bipolar without borderline. These folks are also often reporting a greater likelihood of some early childhood adversity. So this might be abuse or maltreatment, or other, kind of indicators of a less than supportive environment when they were growing up. Similar to those like rates of comorbid conditions we just saw within these individuals, they're also reporting more mental health conditions in first degree relatives. And yeah, so these are kind of some developmental features to pay attention to that can help differentiate folks as well. And I think if you're, interviewing folks that you're providing care for, it's important to kind of hear about these things, and also to reflect on in terms of your own experiences. In terms of types of symptoms and experiences that are often reported more by those with this comorbidity than bipolar alone. So these include experiences of what is clinically called transient stress-related dissociation or paranoia. But what this means is sort of more fleeting periods of maybe feeling disconnected from the world, disconnected from yourself, or having more suspicious thinking in the context of a stressful situation. So not experiencing this for the duration of a mood episode, for instance, but maybe for kind of minutes to hours, sort of having this experience of feeling somewhat disconnected or suspicious in relation to a stressful situation. They also report kind of greater levels of rejection sensitivity, so feeling sensitive to abandonment and rejection in interpersonal situations. We've talked about the impulsive behaviors, but impulsive behaviors, particularly in relation to negative emotions or strong emotional states. So, engaging in this because of maybe feeling sad or angry or upset in some way. Suicidal thinking that's related to a breakup or rejection or interpersonal stressor is more common in this group. Kind of more reactive anger or hostility. This is a specific item that is, I think, a little bit heartbreaking, but sort of if others knew the real me, they would not like me. So some self-concept challenges are also a bit more common in this group. And also more difficulty using adaptive coping strategies and sort of a greater likelihood of maybe using, impulsive behavior or sort of more harmful behaviors to help regulate emotions. So interestingly, outside of the last one, which is starred, some of these other items were, kind of used in a study or found in a study to kind of uniquely classify individuals as having the comorbidity versus having bipolar without borderline personality. They actually used a machine learning algorithm to sort of figure out which types of symptoms were likely to identify folks that belong to that comorbid group. And had about an 80% accuracy based on these items, sort of classifying people in one group versus the other. And then the latter is from some additional studies of folks that are reporting this comorbidity. So some differences in, I think, kind of specific symptom areas, sort of what they're in response to, and, kind of some nuanced experiences reported by this group. So what about treatments for this group of people that have these two co-occurring disorders? I will say I'm a psychologist, so most of my expertise is in psychosocial treatments, so I'll spend most of the time talking about that. But I will touch on pharmacological treatments a bit. So like I said, these are first-line treatments for bipolar disorder, medication-based treatments that are adjunctive treatments primarily for borderline personality. And there's some evidence that there can be a worse treatment response for patients with comorbid, bipolar, and borderline compared to bipolar alone, although these findings are a bit mixed. So Swartz and colleagues did a small study kind of comparing those with comorbid bipolar type 1 and borderline personality compared to patients with bipolar type 1 and no borderline personality. These patients were treated with a combined medication and interpersonal and social rhythm therapy. And you can see a much smaller proportion of the comorbid group achieved clinical stabilization compared to the group with bipolar type 1 without borderline personality. Other studies show kind of some mixed findings and find that, often people in the comorbid group can still do quite well on mood stabilizers, although there is some emerging evidence that combination therapy is sometimes more effective for this comorbid group compared to monotherapy. So having multiple types of medications on board compared to, sort of one primary mood stabilizer. In terms of psychosocial treatments, we also know that sort of some of these treatments are often used as an adjunctive to medication for people with bipolar conditions. And there's a pretty robust evidence base for treatments such as cognitive behavioral therapy, interpersonal social rhythm therapy, family-focused therapy. There's also emerging evidence for some what we call third wave approaches, including dialectical behavior therapy, mindfulness-based cognitive therapy. Conversely, for borderline personality disorder, psychosocial treatments represent first-line treatments, again, with a pretty robust evidence base. And so treatments that are often used in treating primary borderline personality disorder include dialectical behavior therapy, mentalization-based therapy, transference-focused psychotherapy, schema-focused psychotherapy, probably with DBT having the largest evidence base right now. These all tend to be pretty intensive treatments. They can be quite lengthy, but sort of have some, despite coming from different sort of theoretical perspectives and approaches, have some similarities in terms of, how they're delivered and what the priorities are. And we'll get into some of the specifics in a moment. But this is kind of the current state of affairs for treatments that are maybe specific to both types of conditions. I think importantly, there's been limited kind of investigations into some of these treatments for folks that have both conditions or features of both conditions. I think there are some interventions that show some promise because they've shown a degree of effectiveness in both groups, or sort of in treating bipolar disorder as well as borderline personality, not necessarily the comorbidity quite yet. So some of these interventions include like psychoeducation. So learning about, this can be multifaceted, and sort of learning about, each condition and how to best manage it. And sometimes this is a component of another treatment. Sometimes they can be sort of a standalone intervention. But there's, evidence for both conditions that psychoeducation can be really beneficial, can help people manage symptoms on their own. Psychoed can be delivered in different formats. So like a group format, a web-based format, there are promising apps out there as well. But we haven't really seen too many studies yet for this particular group of folks that have both conditions. Similarly, DBT, which I mentioned a minute ago, is a treatment that was developed and primarily used for a while in treating borderline personality, but has been now applied to a lot of different conditions. And is sort of this 4-module treatment where there's skills related to mindfulness, interpersonal effectiveness, distress tolerance, and managing kind of crises and really distressing situations, and emotion regulation. And so there has been some research. There's a robust kind of evidence base for borderline personality. There's been some initial research into looking at applying DBT to people with bipolar spectrum illness. There's a recent review by Jones and colleagues that looked at 11 studies and found that in patients with bipolar disorder, it's found that DBT has been feasible to deliver. It's been acceptable to patients, so it sort of makes sense and feels relevant, and may also improve bipolar symptoms, including reducing manic symptoms or hypomanic symptoms, reducing depressive symptoms, and leading to improvements in mindfulness and emotion regulation. I think importantly, this is like a pretty systematic review, and about 10 of those studies were pilot studies, which means they were pretty small scale studies. So there haven't really been these kind of larger scale trials of this treatment for bipolar, or for that comorbid group more specifically. And there's some bit like across studies, a lot of variability in how DBT was applied. So in some cases, it was adapted to bipolar specifically. In other cases, it was just sort of your standard DBT protocol. And these tended to be kind of small groups, but this is still, I think, very promising. And just to kind of summarize some of these findings and talk a little bit about how we might think about using them to help people right now. So we know that both, borderline personality disorder, bipolar spectrum illness are both very serious areas of mental health concern. They meaningfully impact the lives of many individuals. And the evidence suggests that these are two distinct conditions that may impact people in different ways. That being said, there is this kind of meaningful subgroup of individuals who meet criteria for both conditions. Again, that's around 20%, it seems. And on average, having this comorbidity rather than having bipolar without borderline personality, can be associated with a more complicated course of illness. And there aren't great established treatments for this particular group of people. There aren't great established treatment guidelines for how to manage these individuals. So I think folks with this, sort of overlap between having both bipolar and borderline personality, can be in this space where we maybe know less about how best to treat these individuals, or kind of how we can use treatments together. I think in terms of what we can do now to help these folks, and how we can leverage the information we already have. For those of us who are clinicians and also to a certain extent researchers, I think we can help people by screening more for both bipolar illness. Again, probably preaching to the choir here for that, but certainly also borderline personality features, especially when people are presenting to care. There are multiple screening instruments available that are not super well, they're not super complicated to implement. They don't take a lot of time. Some of them are self-report, so patients can also reflect on their own experiences. I think it's also helpful to reassess these symptoms over the course of treatment because our understanding of, folks can evolve over time, and we might get more clarity, in terms of the context of when things happen for folks. So is it happening, in particular types of stressful situations, for instance? Are there themes in terms of the types of, kind of distressing concerns that people bring up, for instance? Do we have more information about the time course of symptoms over time? Sometimes it takes getting to know someone to really kind of clarify those aspects. Um, so we can do more assessment, and more screening, and I don't think it would take up that much time or space. I think, again, on the clinician researcher side, we can educate clinicians, we can educate ourselves regarding some of these more nuanced differences between bipolar and borderline, and also acknowledge that it is possible to have both disorders. There is this concept of like diagnostic overshadowing where we feel like we have to pick one over the other. But for, subgroup of individuals, it seems to be, most, accurate and appropriate to diagnose both conditions because that captures their experience. When possible, when we have the time, when we have the resources, kind of similar to the first point, I think, using as much retrospective chart review to get as much of like a time course assessment of how someone's done over time, can be really useful if there's a question of if there may be some co-occurring borderline personality or not. Also using informants from someone's life, I think, is always helpful in terms of treatment, but can, also maybe provide some of that retrospective information as well, and more nuanced information about someone's symptoms and experience. I think as all individuals, we can be aware of stigma. We know there's certainly some structural stigma in healthcare associated with both of these conditions. And there are some interventions out there. I know like Knock and colleagues, have interventions around healthcare stigma. And, as individuals with lived experience, there's also self-stigma associated with, all of these conditions. And I know Andrea Vasella, for instance, has an intervention around self-stigma for bipolar. But I think regardless of interventions, it's just something that, I think we need to be aware of some of our own biases maybe, and making some of these clinical judgments or reflecting on our own experiences. And that can be a real barrier to getting people help. More specific to research, I think we can also include more screening for borderline personality or more symptom measures in trials, and also sort of like basic psychopathology research about bipolar disorder. The more we know, the more we can, kind of show associations or lack thereof between people having symptoms of borderline personality and how they do in bipolar treatments. I think the better understanding we can have about how to best help people. And again, it doesn't have to be super burdensome in terms of time or, kind of intensity of the assessment. In terms of interventions that seem promising and, I think can certainly be helpful for folks that, may have this co-occurrence. It seems like DBT, dialectical behavior therapy, as well as, some forms of psychoeducation have some evidence to support their use, and could certainly be beneficial to folks that are, having this co-occurring presentation. We definitely need more trials. We need more varied trials. We need greater numbers of people being studied. But these interventions both seem to help people with bipolar disorder as well as borderline personality. So I think that, definitely lends some support to using them. I think there's also, some room to think about how we might integrate existing evidence-based interventions as we're kind of thinking about planning additional treatments, and additional trials to see what's effective. So there's been like a proposal from Bailey and colleagues looking into combining DBT with interpersonal and social rhythms therapy, which sounds very cool and promising. There's been some work by Ryman and colleagues combining STEPS, which was a different borderline personality treatment, into bipolar outpatient care, sort of more usual care, and that's shown some promise. So I think there's also some opportunity to be creative about combining some of these treatments that have evidence base for both conditions. Um, and I think that might be all I have for now. I didn't time myself, but I did okay. So I thank you all for listening. And my email is there, and you can probably Google me easily and find me if there are follow-up questions that we don't get to today, or any way I can be helpful. So thank you all.
Of course, perfect. Well, Dr. Temes, that was more than okay. That was perfect, right on the dot. And yeah, we're gonna go into the question and answer portion of today's talk now. So please drop your questions in the question box. We're gonna try to get to as many as we can today. And so first question is, can borderline personality disorder have psychotic symptoms and doctors prescribe the same medications as used for bipolar?
That's a great question, and I think I think definitely doctors can prescribe similar medications that are used in bipolar, and often we see people with borderline personality, um, you know, on a lot of like anticonvulsants, sometimes mood stabilizers, sometimes atypical antipsychotics. I think the typical kind of psychotic-like experience that people with borderline personality report is that kind of transient stress-related paranoia and dissociation I mentioned earlier. So that's sort of having some heightened suspiciousness or paranoia that's usually relatively short-lived and in response to a stressor that's happening. So not lasting for days or weeks at a time necessarily, but sort of, within a day, something stressful happens, and then people kind of report having this experience. And sometimes people report, other types of, you know, cognitive type experiences that are sort of within that realm, often in response to stressors that are, maybe don't quite meet the threshold of psychosis per se. And sort of how you might define that as more about like, a condition sort of, typified by that. But, could still be characterized by like some heightened suspiciousness or, maybe more unusual beliefs about a situation that again tend to be, relatively fleeting rather than long lasting and typically in response to an event.
Thank you. And our next question is, what screenings do you recommend to help achieve a diagnosis of borderline personality disorder and bipolar disorder, if that is the case?
Yeah, sure. I think for, bipolar, I think just making sure that we're assessing for, um, mania and hypomania symptoms sort of on the front end. So, using tools like the Altman and other screeners for mania and hypomania, I think is important. For borderline personality, one screener is like the McLean screening instrument. It's a 9 or 10 item screener, kind of yes, no questions that I think can be administered either by a clinician or a patient can do a self-report version, relatively quick, kind of gives a snapshot of, if these experiences are relevant in someone's life. So I would definitely recommend that one. I think it's pretty easy to implement and gets at all the symptoms of borderline personality. And then there's some, kind of, if you want to get more nuanced information, there are instruments like the DERS, which is a emotion regulation survey that can maybe get into some other areas um, of symptomatology and really get into like the types of emotion dysregulation problems that someone's reporting. That one's not really like a diagnostic screener, but there are definitely tools around specific symptom areas that can also be helpful.
Mhm. Well, excellent. And then moving forward, our next question is, how does a diagnosis differentiate between an individual who has rapid cycling bipolar disorder and someone who has borderline personality disorder?
Yeah, that's a great question as well. And I think kind of an area that can be a little bit more difficult, especially with a time course issue when it is really rapid. I think often, when people are kind of reporting rapid cycling, there's still, um, the time course might, still be somewhat longer than what we are typically talking about in borderline personality, where, um, like I said, the time scale can sometimes in the mood reactivity be in, the seconds to hours kind of category. And people often are reporting, kind of more baseline reactivity that can move in a lot of different directions. So not just sort of the poles between mania and depression, but to anger or extreme anxiety or extreme sadness, kind of depending on whatever the situation is. So I think time course is still relevant and still might be quicker, so to speak, in borderline personality compared to the rapid cycling. I think also probably even more importantly than that, because I think we can probably get in the weeds of the time course of mood affect changes, are that, there are other symptoms of borderline personality, not just related to affect. And these include concerns about abandonment, sort of difficulty in relationships. So having, a lot of reported experiences of unstable relationships, that stress related paranoia we talked about already, kind of more extreme anger, self-harm urges, impulsivity that's a bit more chronic. So not just during certain types of episodes. And so, I think we want to think about sort of the constellation of features that are common for folks across time. Doesn't mean people are experiencing every single symptom on every day, but that it's something that they're generally reporting, kind of having to manage, having to regulate across time, versus it maybe being confined to certain types of episodes or, kind of certain type of circumstances, which I think, maybe more the case for rapid cycling, although, I admit that does require sort of a nuanced diagnosis and a lot of follow-up.
Well, thank you. And the next question is, has there been any research done in the area of ketamine treatment for co-occurring bipolar disorder and borderline personality disorder?
I can't say with 100% certainty, but I don't recall reviewing any literature on that particular treatment. And I think in general, looking at treatments for the comorbid group are relatively limited. But it seems certainly an area that's worthy of further investigation. As is the case with a lot of these different treatments that can be beneficial for one group or the other.
Perfect. And then our next question is that one of our audience members has said that they have read clinicians are more inclined to diagnose bipolar disorder over borderline personality disorder due to possible insurance-related problems. Is this something that you notice happened?
I don't know that that's necessarily too much of a concern any longer, but I think there has been, so I can't necessarily speak to that issue sort of as a clinician in a hospital setting, in terms of our current guidance on billing and insurance. I think both are, kind of, considered, mental health conditions that we can certainly bill for. And that being said, I think there, I think there's probably a lot of folks that, regardless of the billing issue, may learn later on that they have borderline personality disorder that better captures their experience who were previously diagnosed with bipolar disorder and vice versa because of some of this confusion that we've talked about. But, my position as a clinician is if you really believe it's, kind of one condition over the other, I think that's what we should, kind of certainly bill for. And I think certainly kind of having more evidence about these treatments as well, kind of helps support the payer side as well and make sure that, we can provide these treatments that are effective for both conditions.
Excellent. And then moving forward, it looks like we have time for about 2 more questions here. And this question is, how can someone help educate people on their borderline personality disorder?
Yeah, that's a great question. I wish I had my book recommendations with me, but there are some volumes out there, about living with borderline personality disorder. John Gunderson, who's a late psychiatrist who worked at McLean Hospital, has published a few of those. There are great resources out there. There are quite a few websites about DBT type of skills that also include some psychoeducation around borderline personality disorder. So DBT self-help is one of them. That's a bit, kind of I think has some lived experience leads kind of contributing to that website. There are also, some advocacy groups, including NEA BPD. I think it's the National Education Alliance for BPD that has a lot of great resources, and is sort of a group that includes clinicians, researchers, and people with lived experience. There's a group out of New York called Emotions Matter that is more exclusively a lived experience group. I think they have peer support groups as well. And Tara, BPD, they all have educational resources that are easily accessible, free online, and recommendations for other books and resources that are out there if people are looking for more information.
Well, excellent. And, we'll do our best to compile all those resources. So please email info@ibpf.org if you would like any of those. And our last question of the day is, well, it starts off with a thank you so much. So we want to say thank
Thank you. You're welcome.
you. They're wondering if Seroquel has shown any efficacy in treating borderline personality disorder.
That's a good question, and I will present this with the caveat that I'm not a pharmacologist. I think that there are, quite a few people with borderline personality who are treated with Seroquel. And my understanding is, kind of a lot of the atypicals are helpful for treating kind of specific symptoms of borderline personality. So often, a lot of them are used for treating like impulsive and kind of more riskier behaviors, or suicidality, and kind of taking the edge off of some of that mood reactivity. People, may still have some other active symptoms or symptoms that they're addressing in other ways through like, therapy-based interventions, using coping strategies. But a lot of the, atypical agents and other types of medications that are used tend to target more specific symptom areas in borderline personality.
Excellent. And so that's about all the time we have today. Dr. Temes, I want to thank you so much for joining us for today's webinar and contributing your knowledge and your time, to truly make a difference with our community. And we're so thankful. And I also want to wish everyone a happy World Mental Health Day. As we discussed earlier, IBPF is here for you. We have resources. We can help you find treatment. We'll provide you with the best answers we have to your questions. So please feel free to reach out to info@ibpf.org with, any comments, questions, or concerns that you may have. And I would like to let everyone know that this video will be uploaded on ibpf.org under our educational video section and on our YouTube channel. And Dr. Temes, would you like to have any closing remarks?
No, just thank you again for having me, IBPF, and for everyone for attending. And I hope this was kind of helpful in, sort of highlighting, I think a really kind of important co-occurrence of conditions that can be quite challenging, but I think there's a lot of promise in terms of thinking of ways to help people and, kind of include methods that into things that we're already doing to better understand folks and help them as best we can. And thank you, and happy World Mental Health Day. I'm so happy to be here today.
Well, very well said, Dr. Temes. And everyone, I hope you have a fantastic day.